Okay, good morning, guys. So let's start the class. So today I'm going to talk about vesiculobullous disorders or vesiculobullous diseases, one of the important topic in dermatology. And under this topic, I'm going to talk about Pemphigus vulgaris, one of the commonest type of vesiculobullous disease, followed by bullous pemphigoid, and then dermatitis herpetiformis. All of these can be asked in your exam. And when you start, if somebody is planning to become a dermatologist, or sometimes you don't need to be a dermatologist to see skin diseases, so you can even diagnose these conditions if you go through these topics well. So let's start. Before going into the topic proper, let's know what is vesicle and bulla, though I'm 100% sure all the students know this. Vesicle means a clear fluid filled lesion just below the epithelium, and the size is less than 5 millimeter, whereas bulla is larger than that. Okay, please mute yourself, and bulla is larger than that. So that is the difference. Now look at this slide, which is clearly telling us uh, this keratinocyte, okay, on the skin. See here, this is stratum corneum, okay, the uppermost layer, stratum corneum, stratum granulosum, stratum spinosum, okay, then stratum basal. There is no stratum lucidum here, so this is the thin skin we are talking about, thin skin. And here is the dermis. So basement membrane is separating dermis from epidermis. Now, why am I including this slide here? There is a very important meaning. These diseases, which are known as vesiculobullous disease, mainly Pemphigus vulgaris, okay, it develops in the superficial layer of the epidermis, and these keratinocytes, the cells of epidermis are known as keratinocyte. They are connected with each other, or they join with each other with desmosome, and the stratum basal cells are connected with basement membrane by hemidesmosome. So this type of diseases are all about destruction of the desmosome and hemidesmosome. Okay, I want to give you this important point right in the beginning, so that when I move further, you can understand this topic very well. See here. Now let's talk about what are these desmosome and hemidesmosome. See this. This is a schematic diagram, but it is very informative. These are the different keratinocytes, for example. Okay, different skin cells. Now there is a substance, okay, which is connecting these two cells. It is also here. These cells and these cells are connected by this attachment. This is called desmosome. Okay, this is called desmosome. Now on the other hand, the basal surface of these cell is connected with basement membrane. This is basement membrane here. Okay, this is called hemidesmosome. Hemidesmosome, and these elongated uh, you know structures are filament. Now see there. Okay, number one is filament, number two is desmosome, number three hemidesmosome, and number four is basement membrane or basal cell layer. Now a bit of another picture regarding desmosome. So what is the important structures in desmosome? Now this is one cell, okay, cell number one. This is cell number two, and this is the connection between them. Okay, connection between them. This is the desmosome. You don't need to know in detail regarding this. Just build a concept here. Okay, nobody is going to ask you draw a diagram regarding desmosome. That is not our concern. Our concern is why these vesiculobullous disease develop, what is the pathophysiology, what is the clinical feature, and how do you manage. Now with this a bit of background information, let's classify these vesiculobullous diseases. See here. Now these diseases are classified into two big headings first. One is called intraepithelial vesicle and second is subepithelial vesicles. Intraepithelial and subepithelial. Now let's talk about intraepithelial first. In this condition, the lesion is formed within the epithelium, and these can be acantholytic vesicle and non-acantholytic vesicle. Now, acantholytic and non-acantholytic. Now, what do we mean by this acantholytic vesicle? This is because of the breakdown of specialized attachment called the desmosome. Just now I showed you what is the desmosome. So these desmosomes are broken, they're destroyed in acantholytic vesicles. That means there is no attachment between the cells. Cells are free now. Okay, and the common disorders are Pemphigus vulgaris and Pemphigus foliaceus. Vulgaris is much more important than foliaceus. We are going to talk in detail about each of them. Among the non-acantholytic vesicle, it is usually seen in the viral infection. Usually seen in viral infection because of the death or the rupture of the group of cells. So these are also the cause of vesicle, but these vesicles are not associated with destruction of desmosome. This is important one. That's why they are known as non-acantholytic vesicle. A common example you can give is herpes virus infection, varicella zoster virus infection, which is clearly causing vesicle there. Another group, subepithelial vesicle. That means the lesions are formed between the epithelium and the lamina propria. Okay, between the epithelium and the lamina propria. And these are erythema multiforme, a type of drug reaction, pemphigoid, okay, or bullous pemphigoid is the better term here, and even dermatitis herpetiformis. So from this list, we are going to talk about Pemphigus vulgaris and foliaceus, pemphigoid or bullous pemphigoid, and dermatitis herpetiformis in today's class. Let's move further. Let's talk about Pemphigus vulgaris as the first one. Now, this is an autoimmune disease. This is an autoimmune disease of the skin and mucous membrane. This is very common in Ashkenazi Jews and Mediterranean people. Okay, but having said that, it can be seen all over the world. They are more common in those races. That's the meaning. And middle-aged females are more commonly affected than the male. Okay, which holds very true, isn't it? Because most of the autoimmune diseases are more common in females. Now, what are the clinical features? Let's talk this first, and then we move on to the pathophysiology a bit later. Because more important pathophysiology you have already known, destruction of desmosome. Now see here, there are formation of painful ulcer and erosions or bulla. Okay, these bulla are bigger type of vesicles, so they are filled with fluid, and usually the fluid is clear. So painful ulcer or erosions are formed along with bulla. Now one important point you need to understand, in the beginning there is bulla or vesicle. Now these bulla and vesicles are ruptured very easily because they are present quite superficially, and after they are ruptured they form ulcer or erosion. This is the meaning, and these are quite painful. They can be formed anywhere in the oral cavity, okay, or on other areas as well. They are not pruritic, they are not itchy. Pruritus means itching, so they are not itchy. These bulla ruptured very easily because they are quite superficial. Okay, they are quite superficial. See here, the bulla is rapidly ruptured. Now there is one important sign which is called Nikolsky sign, and you have already learned that before. This Nikolsky sign means there is easy removal of the skin by just a little pressure from the examiner's finger. Okay, I need to give a gentle pressure on that area and the whole skin is removed like a fold of sheet. This is Nikolsky sign. And this Nikolsky sign is also positive in staphylococcal scalded skin syndrome, which you have learned before. It is also present in some other conditions. Sometimes the multiple ulcers, they are fused with each other and form a bigger ulcer, and this condition is very painful. Of course, a big ulcer is there, it is quite painful condition. So these are some of the clinical features of Pemphigus vulgaris. Let's move on. Now, it has quite a variable course. This Pemphigus vulgaris has a variable course, means we cannot predict it. Okay, we cannot predict. You cannot pinpoint. Oh, this thing is going to happen, because it has a variable course, and it might involve skin, esophagus, as well as cervix. Remember, skin and mucous membrane both are involved. Now, when this bulla are multiple and when they rupture, they can cause a lot of raw area on the skin, isn't it? When the skin is damaged, then raw area will be formed, and from that raw area, proteinous fluid or protein rich fluid and electrolytes can be lost. Proteinous fluid and electrolytes can be lost. This is important, complication. Secondary infections and weight loss can also occur, because this is a chronic type of inflammatory disease, so weight loss can be there. This is again a result of different cytokine in the body, and secondary infections are quite common because the superficial layer of the skin is lost. Now there are some changes which occurs in the nail. Okay, changes occur on the nail. Let me describe this first and we'll go to the picture. Okay, now what happens in the nail? Now this nail, okay, there is acute or chronic paronychia. Please mute yourself, guys. There is acute or chronic paronychia, subungual hematoma, and nail dystrophy, which affect one or several finger or toes, and these have been reported with Pemphigus vulgaris. So there is affection of the finger. This finger may be infected, which is called paronychia. There is deposition of blood clot, subungual hematoma, and nail dystrophy. What? So let me mute, okay? That guy is not listening at all. So let me mute all of you now. Now let's see how it looks. See here, this is extensive involvement of the body, okay, by Pemphigus vulgaris. Most of these bulla or vesicles are quite superficial, so they get ruptured, leaving behind this raw area on the skin, and this is a painful condition. This is on the upper part of the chest or neck, you can say, and see other parts of the body are also involved. The anterior abdominal wall, even the breast is affected here, the thigh, okay, on the side of the abdomen. Now these are, okay, see here, this is inside the oral cavity. Okay, these are the ulcers which are occurring inside the oral cavity. So these can occur, and this is the skin as well as mucous membrane, both are affected in Pemphigus vulgaris. This is a painful condition. Now after that, let's talk about what is the pathogenesis of Pemphigus vulgaris. Regarding the pathogenesis, it is an autoimmune disease, okay, and we really do not know what is the cause of this. So autoimmune disease of idiopathic nature, but sometimes some of the drugs are the culprit here. They just start that autoimmune reaction, and these drugs are AC inhibitor and penicillamine. Now we all know AC inhibitors are the very important drug used in clinical practice, antihypertensive drug, okay, drugs used in cardiac failure, even in ischemic heart disease. AC inhibitor, sometimes they may be associated with autoimmune phenomena or mechanism like Pemphigus vulgaris. And penicillamine is the drug we use for the treatment of Wilson disease. Now there are circulating antibodies of type IgG here, okay, type IgG. So these autoantibodies are mainly IgG in type, and the most important point is these autoantibodies are targeting desmosome. Okay, they are targeting desmosome, which leads to destruction of the desmosome. Now, what happens if desmosomes are damaged or destroyed? There is loss of attachment from cell to cell. So this cell will become free now. They can change the shape a little bit because they are not connecting with something else. So this is a very important point in Pemphigus vulgaris. So main thing is destruction of the desmosome. Okay. Now see here. Regarding the histopathology of Pemphigus vulgaris, histopathology, if we take a biopsy from there and study it under the microscope, what are we going to see? There are formation of intraepithelial vesicle or bulla, okay, because of acantholytic mechanisms. So intraepithelial vesicle or bulla are formed because of acantholytic mechanism. Now acantholysis means destruction of desmosome. Here acantholysis, this is important term. These changes occur mainly in the stratum spinosum or the prickle cell layer. Stratum spinosum is also known as prickle cell layer, not a very commonly used term. Everybody knows stratum spinosum. It is one of the layer in epidermis. So it is mainly affected. The inflammatory cells are very scanty. Okay. However, some of the eosinophils can be seen. Eosinophils are a part of autoimmune disease. Any autoimmune disease, there are presence of eosinophils. Okay, not that high amount, but some eosinophils are definitely there, and this is not an exception. Now, the most important point in histopathology is the presence of Jank cells. Okay, we have talked about this before, if you remember, Jank preparation and Jank cells. Now, these Jank cells are formed because of acantholysis or because of the destruction of desmosome. Now, how they look? These cells lose their polyhedral morphology. They lose their polyhedral morphology and they become small and rounded. Okay, they look a bit of rounded and they contain hyperchromatic nuclei. These are the hallmarks of Jank cells. So they look rounded, they lose their connection, and their nucleus is hyperchromatic. These are called Jank cells. Now look at this, and it will be very clear to you. Okay, always compare and contrast between the things here. Now, let me highlight. So see here, this is epidermis. Okay, epidermis, and look, where are these bulla or vesicles? Now these are quite small, so I like to call them vesicle here, and these are the empty spaces, means these are the vesicles. These vesicles are present in that epithelial area. It is not very deep, it is quite superficial. This is the hallmark of Pemphigus vulgaris, and because of this they can be ruptured when the patient come to hospital. They're already ruptured, and these are called Jank cells. Okay, they are separated from each other. Okay? Different stains are used, so these are Jank cells, a bit rounded type of cells. Now, how to confirm the diagnosis in case of Pemphigus vulgaris? The one is skin biopsy, which we have just seen. Okay, histopathology, appearance, typical. Another one is electron microscopic examination. Now, if we do electron microscopic examination, we can see splitting of the desmosome junction. With light microscopy, that cannot be seen. We need electron microscopy to see the splitting of desmosome junction in case of this disorder. But electron microscopy is not done for the clinical diagnosis. Okay, this is done for the research purpose only. Immunofluorescence microscopy also can be done. Now, this immunofluorescence microscopy is all about deposition of antigen and antibody on the surface. Now, here there are autoantibodies present. An antigen is desmosome, So that type of thing can be seen under immunofluorescence microscopy. Remember the meaning of fluorescence here. Fluorescence means it just change its color so that we can easily see there. And ELISA can be done to detect the antibody. Now, some of the differential diagnoses are there for Pemphigus vulgaris, which every student should know, and these are pemphigoid or bullous pemphigoid. Now, there is a very important point which is separating these two. In Pemphigus vulgaris, the lesion is present quite superficial, and by the time the patient comes to hospital, many of them are already ruptured, leaving behind the ulcer there. Whereas in bullous pemphigoid, the lesions are deeper. Okay, the lesions are deeper, so they are still intact when the patient visits the doctor. And they are tough type of blisters, not easy to break or destroy. This is bullous pemphigoid. Dermatitis herpetiformis is another differential diagnosis, and if you clearly remember, this is a part of celiac disease. Celiac disease is an autoimmune disease which is causing destruction of villi, and it is associated with gluten food, so also known as gluten associated enteropathy. Staphylococcal scalded skin syndrome is another differential diagnosis where Nikolsky sign is positive, but it is very easy for us to diagnose because many of these patients are children or babies. Okay, and in them Nikolsky sign is positive, but Nikolsky sign is also positive in Pemphigus vulgaris, but the age group is completely different here, and this disease is caused by bacterial infection, Staph aureus. One more important differential diagnosis is TEN, a toxic epidermal necrolysis, the most severe type of drug reaction we know. The most severe type of drug reaction we know is TEN. Okay, so here the epidermis is necrosed and it is getting separated from the deeper area. In this condition also Nikolsky sign is positive. Now let's talk about what is the course or natural history of the disease. Regarding the course or natural history of Pemphigus vulgaris, okay, it is prolonged and it is quite difficult to explain to the patient. Okay, this is called remission and relapses. Remission and relapses. Now, when we say, "Oh, you are getting better now, don't worry, the disease is never going to come back again." Now, after 1 to 2 weeks or 1 to 2 months, again the patient will come to the hospital with same problem. So this is the classical nature. The mortality rate of Pemphigus vulgaris is 15%, about 15%. Okay, and you know what are the causes of mortality? Because of the rupture, extensive rupture of those vesicles and bulla, there is high chance of infection. There is high chance of dehydration, electrolyte imbalance, okay, as well as malnutrition. With modern treatment, most patients with pemphigus can live relatively normal life with occasional exacerbation. This is a very good point. Okay, now look at the complication here. They are inevitable. The complications are inevitable. We cannot, avoid them. They will happen because the steroids and immunosuppressive drugs are used for the treatment, and there are so many problems associated with these medicines. Infections of all types are common here. Okay, infections of all types are common here. Let me, underline the important terms so that it will be easy for you. See here, the steroids and immunosuppressive drugs. These are used mainly for the treatment purpose, and they are associated with a lot of side effects. Infections of all types are common here. I already told you the reason. And severe oral ulcer, making the eating very painful, so the person avoid eating simply because of the pain. Okay, and that can cause malnutrition. Now the final part is what is the treatment of pemphigus vulgaris. So this is autoimmune disease. So corticosteroid play a big role here. Okay, systemic corticosteroid like prednisolone. And if prednisolones are not that effective, you can add some other powerful immunosuppressive agent like azathioprine, methotrexate, and cyclophosphamide. Now after this, let's talk about one of the related condition, which is known as pemphigus foliaceus. Now what is the meaning? In this condition, the blisters are present high in the epidermis, okay, either in the granular layer or just beneath the stratum corneum. What does that mean? They are present even superficial than in pemphigus vulgaris. Okay, even superficial than pemphigus vulgaris. Okay, now see there. So when the patient comes to the hospital, they have high chance of rupture already. Antibody binding may have a direct effect on the function of the desmosomal cadherin in the upper epidermis, causing detachment of keratinocyte. So similar type of mechanism. Those autoantibody are targeting again this desmosome. This is the component of desmosome, cadherin. So it leads to detachment of keratinocytes from each other. Same thing. Desmoglein is present but only weakly expressed in mucosa, accounting for the lack of mucosal involvement in pemphigus foliaceus. Okay, so what they are explaining here is in pemphigus foliaceus there is lack of mucosal involvement. Only skin is more commonly affected because of this particular mechanism. Desmoglein I is absent there, and that is the reason. Now, regarding the clinical features of pemphigus foliaceus, okay, the onset is usually insidious with scattered scaly lesion which involve the seborrheic area. Now, small information here, seborrheic area. Seborrheic area means, look at the example here, scalp, face, upper part of the chest, and upper part of the back. These are called seborrheic area. And seborrheic dermatitis, which is very unrelated condition, okay, which is very unrelated condition, and just comparing the things here so that you can easily remember it, involves all these area. Seborrheic dermatitis can affect this area, and in seborrheic dermatitis there is greasy scale form, that is a hallmark. So scalp, face, chest, and upper back, same areas are affected by pemphigus foliaceus as well. Blistering may not be obvious. Blistering may not be obvious because they are superficial and they rupture very easily. So by the time patient comes to us, those blisters are not there. Only the edge of the blister can be seen. Mucosal involvement is not very common, so oral lesions are uncommon in pemphigus foliaceus. In comparison to the pemphigus vulgaris, it is considered a benign disease, and one of the important reasons I like to highlight here is mucosa or mucous membrane are not affected. Okay, that uh, is a huge point for the patient. Think about it. Oral cavity is not affected. That means patient can eat well without any pain. This is a very, very important point during the management. Now, some of the pictures regarding pemphigus foliaceus. These are the lesions, okay, which you can see clearly. Now, there is no blister now. Blister is already ruptured, but I can still see the edge or some scab which are dried. And this is extensive involvement of the back by pemphigus foliaceus. Now, look at the histology here, or histopathology you can say. See here, this is stratum basal. Okay, stratum basale. This is dermis, isn't it? Dermis, and above this basement membrane of stratum basale, everything is epidermis. Now look, where are those empty spaces? See here, a lot of empty spaces are present quite superficially, even superficial to Pemphigus vulgaris. This is a very important picture if you want to understand the disease process. Now treatment, okay, a bit similar, okay, a bit similar to Pemphigus vulgaris. In this condition, potent topical or intralesional steroids or oral steroids can also be used. Depends. If the affected skin is not that extensive, then we can go for potent topical or intralesional steroid. And if it is extensive, then you can go for systemic or oral. Azathioprine or cyclophosphamide are also effective adjuncts to the oral steroid in severe cases. You can just simply add them together. Adjunct means we add them together, or you can replace oral steroid with azathioprine or cyclophosphamide also. Now, one other type of therapy is intravenous immunoglobulin. It has been reported as effective in resistant cases. Probably it will work as a you know uh, remember the same mechanism we have discussed in different autoimmune disorders. Probably they occupy the binding site. Okay, they occupy the binding site so that they don't allow those autoantibody to bind and destroy the target cells. So this is the mechanism. This is Pemphigus foliaceus. Now, after this, let's enter into the bullous pemphigoid, another type of vesiculobullous disorder. This disease mainly affects elderly people with onset occurring after 60 years of age. So they occur mainly in the older generation or older people. The age difference is important in Pemphigus vulgaris. Pemphigus vulgaris usually the middle age. Okay, females are more easily affected. In bullous pemphigoid, older people are mainly affected. But overall, it is more common than pemphigus in the general population. More common is bullous pemphigoid. Now, one of the most important point I'm going to talk here, that is the blister in bullous pemphigoid is subepidermal with an intact and often viable epidermis forming the roof. So what is the meaning? So the blisters are subepidermal. That means they are not easy to rupture. By the time patient comes to us, we can still see intact vesicles and bulla, because above them a good thickness of epidermis is still present. So it doesn't allow easy rupture of the vesicle or bulla. This is absolutely important point to separate between Pemphigus vulgaris and bullous pemphigoid. Now, bullous pemphigoid commonly starts with itching. Itching is not common in Pemphigus vulgaris, and a non-specific rash on the limb that may either urticaria-like, or occasionally eczematous, and rarely may simulate vesicular eczema. Now, there are rashes present in this disorder, and those rashes are urticaria-like. Remember, urticaria is an example of type 1 hypersensitivity reaction. In urticaria, there are a lot of itchy rashes present on the skin. This very itchy condition. Itchy rashes present on the skin, and they are edematous rash. When we feel them, they felt like they are elevated from the skin. Urticaria. Eczema is a dermatitis, another itchy type of condition. So some of the feature may look like these also. Now let's move further. In bullous pemphigoid, the blisters may arise on erythematous and on normal skin and may be associated with dermal edema. So one other point, they may be associated with dermal edema, and the blisters are tense and dome shaped, and they have a diameter of many centimeter. Sometimes they can be really big also. Sometimes small, sometimes big. They may reach up to centimeters. The blisters are tough. We already talked so many times. They may remain intact for several days, and the contents often become jelly-like with coagulated fibrin because they are present for longer duration. That's why there will be some changes inside the blister or vesicle. They become jelly-like with coagulated fibrin. Somehow, if they are ruptured, exactly this type of substance would come out. Another important point which separate it from Pemphigus vulgaris is the mucus. Now, the important points in bullous pemphigoid are the age. Okay, they are relatively older people in comparison to Pemphigus vulgaris. The second point in them is the bulla which are formed are deeper. They are usually subepidermal, and because of this they are tough to rupture. So by the time patient comes to the hospital, we can still see a lot of blister and bulla. Third point, they sometimes are associated with some rashes on the body, and those rashes may look like urticarial like rashes and eczematous type of rashes, and they can be itchy as well. Mucosal lesions occur very less frequently in bullous pemphigoid in comparison to Pemphigus vulgaris, and bullous pemphigoid is associated with dermal edema as well. These are the things which we have discussed before the break. Let's move on. Now see this picture here. Look at this. This bulla I can still see. Okay, it's still not ruptured. Okay, and if I see it very carefully, there is a thick type of secretion. Okay, inside this thick type of collection, like a fibrinous substance. So these are important point, and a lot of other rashes are also seen in the body. Now another picture of bullous pemphigoid. See this? Look at these blisters, okay, or bulla here. Okay, they are a little bit about to rupture, some of them, but still not complete ruptures. Okay, here I can see it very prominently. Here also, and in this area also, I can still see them. So bullous pemphigoid. Now, what type of disorder is this bullous pemphigoid according to the pathogenesis? Just like Pemphigus vulgaris, it is also an autoimmune disorder. Also a type of autoimmune disorder. So serum from about 70% of the patients of bullous pemphigoid contain IgG antibody, and that IgG antibody bind in vitro to normal skin at the basement membrane zone, that is the border of dermis and epidermis. That's why we talk about hemidesmosome in case of bullous pemphigoid. They are targeting hemidesmosome, which are present at the junction of epidermis and the dermis, or they are connecting those basal epithelial cell with basement membrane, and antibody in bullous pemphigoid are targeting those hemidesmosome. So they are idiopathic. Most of the cases are idiopathic, just like Pemphigus vulgaris, but sometimes some sulfa drugs may be responsible. Okay. Sulfonamide group of drugs may be responsible as a triggering or precipitating factor. Okay, let's move on. Now, see this histopathological slide and compare this slide with the slide which you have seen before. You see here, this is epidermis. See here, this is epidermis. Now, this is the basal layer of the epidermis. Above all area is epidermis. This area is dermis. Now, look at where are the empty space, the bulla. They are subepidermal. Subepidermal, this is the very important point. That's why they are tough to break. This is bullous pemphigoid. So in your exam, some of the examiner, okay, can simply take this histopathological slide and then ask you what are the findings there first, and then the diagnosis. You have to exactly describe what you see here and then give the differential diagnosis. In this type of picture, the first is bullous pemphigoid. Now, what is the natural course, okay, or natural history of the disease? The untreated bullous pemphigoid may run a chronic self-limiting course over a number of months or years. Even without treatment, some of the patients may get better. And the duration of disease is usually 3 to 6 years, with most of the patients achieving complete remission even without treatment. Okay? Even without treatment, some of the patients get completely better. And these are the treatment: topical and systemic steroid, okay, similar because the mechanism is almost same, autoimmunity. And for localized bullous pemphigoid, this BP, bullous pemphigoid, very potent topical steroids are often sufficient. So what is the lesson you have learned? The treatment is a bit easier than Pemphigus vulgaris, okay? Because even the potent topical steroids can be used in case of limited type of involvement. Potent. Now let me remind you, the potent topical steroids are betamethasone and dexamethasone and clobetasol. Okay, clobetasol. These are the commonly prescribed one. Even fluocinolone is the topical one. Betamethasone, dexamethasone, fluocinolone, and clobetasol. These are the very potent corticosteroid. Another one is an oral corticosteroid therapy, which is also known as systemic corticosteroid therapy, can be tried. And even tetracycline or erythromycin with nicotinamide is alternative to steroid. But we really do not know what is the mechanism of action of this in this case. Nicotinamide is vitamin B6, okay, sorry, B3, okay, B3. Niacin or nicotinamide is vitamin B3. So B3 along with these antibiotics can be tried, which are alternative to steroid, but the exact mechanism is not known how they act here. Now the last part of this important topic is dermatitis herpetiformis. Now, when you are learning internal medicine, okay, you have already gone through this topic. It's a part of celiac disease, and celiac disease causes chronic malabsorption and diarrhea, and it is an autoimmune type of condition. Now, that will clearly, put you in a good frame of mind before I enter into this discussion. Dermatitis herpetiformis. Now, according to the definition, this is a rare, intensely pruritic, chronic, recurrent papulovesicular disease. So this is a very pruritic or itchy condition. This is a chronic disorder. It is recurrent. Even after treatment, it may come back again. And in this condition, there are papules as well as vesicles present on the body. Now the important point here, there is an underlying gluten sensitive enteropathy that may be asymptomatic. So if you remember, we clearly talked this point in celiac disease. Almost 70 to 80% of the patient of celiac disease are asymptomatic. They have very minor type of symptom. Okay, the same thing is written here as well. They are having that thing inside, but they are not showing any symptom and sign. And on top of that, they may be having dermatitis herpetiformis. These gluten containing foods are wheat, rye, and barley. So if somebody is taking them, then they can have dermatitis herpetiformis also. Now the mechanism of this disorder, see here, after ingesting the gluten containing food like wheat, rye, and barley, okay, there is inflammation, and this inflammation is occurring on the skin in this case. Definitely, the inflammation also occur in the GI tract, but we are not concerned about that now, right? That is a separate type of condition, though they are very strongly related with each other. Let's focus ourselves on skin part. Now, on the skin, okay, on the skin is IgA is the common type of antibody which is causing problem. See here, granular IgA deposition in the skin, and that will cause blister formation. There is a family history of dermatitis herpetiformis or celiac disease in 10% of the patient, only in 10%, so not a very important point. Now let's talk about pathogenesis, how the damage has been done. The IgA deposit are gluten dependent and are deposited in the papillary dermis and slowly cleared from the skin once gluten is removed from the diet. Now let's not forget, this is a part of gluten sensitive enteropathy. So gluten containing food are important regarding the pathogenesis of this disorder as well. They only happen after the person eat those type of food. Okay, so IgA type of antibody are important here. They are deposited in the papillary layer of the dermis. Papillary layer of the dermis means subepidermal, and they are slowly cleared from the skin once gluten is removed from the diet. And this is one of the main therapy or treatment in case of celiac disease or even dermatitis herpetiformis. Gluten containing food should not be taken. Now, these autoantibodies are against tissue transglutaminase. Tissue transglutaminase. Okay. Now, they have got a different name actually. They are called tissue transglutaminase. They are also known as anti-endomysial antibody, and during this condition, they are known as, see here, they are known as epidermal transglutaminase. They are known as epidermal transglutaminase. This epidermal term will make it very easier for you to identify. Yes, this is autoantibody against skin in case of dermatitis herpetiformis. So let me repeat again, tissue transglutaminase, antibody against that, anti-transglutaminase antibody, also known as anti-endomysial antibody, and in case of dermatitis herpetiformis, we call them epidermal transglutaminase or anti-epidermal transglutaminase antibody. Now, what is happening on the skin or in the subepidermal layer? Now, neutrophils and eosinophils accumulate there within the dermal papilla and form microabscess. This is in the papillary layer of the dermis, and they may form microabscesses there. But remember, these microabscesses are sterile type of abscess. Okay, there are no role of any microorganism. The surrounding collagen is degraded, resulting in detachment of the epidermis and subepidermal vesicle. So they get detached from there. Sometimes they may fuse with each other and form bigger blisters. Okay, if you do immunofluorescence study, then you can see the deposition of IgA type of antibody on the dermal papilla. Now this will give us the diagnosis. So let me highlight this. There are granular deposit of IgA in the dermal papilla. This is what immunofluorescence microscopy will show us. And there may also be C3 and IgG deposition in some of the area, but more important is IgA type of antibody. So this is regarding the pathological aspect of dermatitis herpetiformis. Let me remind you again, there is no role of herpes virus here. Though the term herpetiformis is there, there is no role of herpes virus. It is not caused by any infection. This is caused by autoimmune mechanism. Look at this, picture. See here. So this is the epidermis, Okay, this is the basement membrane of the epidermis. These are called dermal papilla, which are going up towards the epidermis. So I can clearly see in the papillary layer of the dermis there is empty space. See here, there are empty spaces there. This is dermatitis herpetiformis. Okay, dermatitis herpetiformis, a part of celiac disease. Now, what happens to the patient now? What are the clinical features? Dermatitis herpetiformis mainly present between the ages of 20 and 55, so quite a variable type of presentation, but it may occur in children as well. And in this condition, the pruritic lesions are formed, and this is a very, very important symptom. Pruritus, itching, extensive itching is there on those lesions. Remember, itching is not a problem in Pemphigus vulgaris, and a slight amount of itching may be present in Bullous pemphigoid, but in this condition, itching is much more severe. Now, the vesicles are usually grouped together on plaques of erythema and rarely blisters 1 to 2 centimeter in diameter. So they don't form big type of blisters, and the reason here we can give, they are subepidermal in origin. That's why. Okay, they are not that commonly seen outside as a blister. Now, where are the distribution? Then the distributions are mainly on the extensor aspects of the limb, like knees. Okay, just below the point of elbow, or you can say back of the elbow, buttock area, and the natal cleft as well. Okay. And in other patient, also the axillary fold, shoulders, trunk, face, and scalp can be involved. But the more important one are the extensor aspects of the limb, okay, as well as body. Now, extensor aspects means if I talk about the body, it's a back, and if I talk about the upper limb, okay, if I talk about the upper limb, just stand in the anatomical, position. Then the back of your upper limb are the extensor aspect, but in the lower limb they are the frontal side. They are not the back side now. They are the frontal side in the lower limb. They are the extensor aspect. Now look at this picture. See here, the back is affected. Look at the back of the elbow. Okay, even the back side of the arm. The elbow is very important part here, around the buttock area, even the natal cleft. Okay, so these are very commonly affected. This is the back of the elbow again, in a little bit magnified view. Now, where are the blisters or vesicles? Not commonly seen. Not commonly seen. Rather, there are some papular type of lesions seen, and they are very pruritic or itchy. The patient may experience bouts of abdominal pain, constipation, and diarrhea. Now, rather than constipation, there is diarrhea, okay, because there is association of celiac disease in this type of persons. Now, one important question you should never forget: some of the associated conditions occur together with all of these diseases. Okay, all of these, not only dermatitis herpetiformis. Remember, even pemphigus vulgaris and bullous pemphigoid, because all of these are autoimmune disorder. So you can write this point here. If one autoimmune disease is present in the patient, other autoimmune disorders may be there. And examples are autoimmune disease of the thyroid gland, like Hashimoto's thyroiditis or Graves' disease. These two you can immediately take as example. Pernicious anemia in case of stomach, isn't it? Then vitiligo, which is called marker of autoimmunity. Addison's disease, type 1 diabetes, myasthenia gravis, so many different things we can include here. Now, lymphoma is a well-recognized complication of dermatitis herpetiformis. Lymphoma can develop in some of the patient, and this is a complication, but not that common. some other picture. Okay, little bit blister form are seen now. Okay, small types of blisters are seen, but in other picture again the blisters are not there. Itchy type of rashes are there. Dermatitis herpetiformis. Now, what is the treatment? Okay, the last part. What is the treatment of this condition? Regarding the treatment, one of the drug is dapsone. Now, this dapsone is anti-leprotic drug. Okay, anti-leprotic drug, and in this condition, the action is thought to be related to the inhibition of neutrophil migration and functions. Okay, but it may help. It is not, universally used everywhere, but in this condition, it may help as one of the drug. Steroids are the important drug here. Okay, steroids are the important drug, especially the topical steroids, topical one. Systemic corticosteroids are ineffective. Topicals are more effective in this case, and systemics contain a lot. Lead a lot of side effect also. So if they are not very effective, then why to use them? So we go for topical. And let's not forget, this is a part of celiac disease. So gluten-free diet is very, very important one. So the diet should not include wheat, barley, or rye. Rather than that, we can include rice. Okay, rice is gluten-free diet. Potato is a gluten-free diet. So those can be easily included.